of the ISCCP series. So 777, 7th of every month, 7 p.m. for 70 minutes. So without any further delay, today we have a very important webinar series on vulvovaginal health. So I will like to now invite Dr. Priyanka Mathe. She's Associate Professor, Obs and Gynae, UCMS and GTB Hospital, and she'll be the Master of Ceremony today. So Dr. Priyanka, over to you.
Thank you, ma'am. Good evening, everyone. So, with the aim of cervical cancer elimination, ISCCP Society aims expanding knowledge and sharing and promoting education through these monthly webinars. So today we expand further knowledge to VAIN and VIN. So without any further delay, I would like to invite our President, Dr. Aruna Nigam ma'am, for the welcome address. Good evening, ma'am. Welcome, ma'am.
Thank you, Dr. Priyanka. So I welcome you all for once again on this webinar on the 7th, which we have decided, and thank you all for joining. This is going to be a very interesting webinar, and before we proceed to the webinar, just to announce, we had a very successful midterms ISCCP CME conducted by AIMS Jammu, which have been attended by Jammu and the other state people in large numbers. So I congratulate the AIMS Jammu team, which have been hosted by Dr. Neha Rathore and Dr. Meeta Gupta, the HOD there at AIMS Jammu. Another announcement is there for all of you that we are going to conduct our annual CME in Chennai, and that will be hosted by Dr. Ujwala. We will be soon sharing the brochure for the same, and I invite you all for attending the same. That will be in the last week of March. The third announcement once again is I would like if you all will circulate our HPV vaccination training module to more and more numbers, so that all of the people who are involved in the screening and in the vaccination, they can be benefited by it. It is open for all the healthcare workers, for postgraduate MBBS students, Ayush, and everyone, and it is free of cost and available at our website. So with this, I hand over the mic again to Dr. Priyanka to conduct the CME.
Thank you so much, ma'am. So let's move on to our first scientific session, Microbes as Guardians, Understanding Vaginal Microbiome, for which I would like to invite our chairpersons, Dr. Sandhya Jain, ma'am. Ma'am is professor at Director Professor at UCMS and GTB Hospital. Welcome, ma'am. Dr. Anjana Chauhan, ma'am. Ma'am is Senior Consultant and Gynae Oncosurgeon.
Priyanka, your screen is not moving. Yeah.
We welcome you, ma'am. And Dr. Archana Chaudhary, ma'am. Ma'am is Senior Specialist at Department of Obs and Gynae, GTB Hospital. Now I would like to invite, request Dr. Anjana, ma'am, to please welcome our speaker for this session.
Yes, thank you very much. I just want to just thank you. 1 minute, I'm not. I just want to thank the ISCCP for inviting me for this special webinar, and especially Dr. Bidya and Dr. Shruti. And it is my pleasure to be on this platform and to invite the speaker for the session. I just...
Priyanka, please show the CV, please.
The CV is there, ma'am.
Okay.
The speaker is Dr. Archana or Dr.
Aruna Nigam.
Dr. Aruna.
The CV is, yes. So I was getting confused. It is my pleasure and it is my honor to invite our Dr. Aruna Nigam. She is the head of the Department of Hermed Institute Medical Science Research and president at present. She's the president of Indian Society of Colposcopy and Cervical Pathology. She has many laurels to her achievements, and she has more than 250 publication, which is a very big thing, and more than 4,000 citations. She's editor of Pan Asian Journal of Obstetrics and Gynecology and Journal of Colposcopy and Lower Genital Tract Pathology. She's a very dynamic person, very bubbly person, and I have listened to her lectures. They are wonderful with lots of insights and input. Madam, please, I invite you for a talk, which is a very new subject now coming up, the vaginal, what we can say, microbiota for the infections, and it is going to be a new thing in near future. Ma'am, please, the stage is yours.
Thank you, Dr. Anjana, for introduction. Uh, uh, can you please, Priyanka, can you please stop sharing? Yeah. So this is a very interesting topic, and every MR must be in front of your room to prescribe their probiotic, prebiotic, symbiotic, and all type of things to you. So before prescribing any of these medication in the course of vaginitis and as a routine, you should know the basic concept of it. So the topic which I have selected is microbes as guardians, understanding the vaginal microbiome. And as the chairperson has taken one more term, microbiota. So you need to understand the difference between the microbiome, microbiota, and the biofilm. But before we go further, we should be knowing what consists of a normal vaginal discharge and how it protects the routine vaginal epithelium. So, vaginal discharge is one of the most common gynecological complaints affecting nearly every woman at some point in her life, regardless of the sexual activity. It can be even presented at the age of 3 years, 7 years, 9 years, 10 years, and it ranges and can go till the 80 years. So, this is one complaint which is a very common complaint, and the patient goes to each and every specialty, especially the gynecologist, but can go to family practitioner also and to anyone also. So many a times people don't come out with it despite so many problems with it. So what I'm going to talk of the vaginal discharge components: microbiome, microbiota, and biofilm, vaginal microbiota and immunomodulatory effects, and the evidence-based use of prebiotics, probiotics in a short. So let's understand what does we all know regarding the discharge. So normal discharge is clear and white, mild with no odor or some amount of odor with a volume of 1 to 3 ml per day. And texture changes from stretchy as per the hormonal menstrual cycle. And women's perception regarding the normal varies because some people don't want any amount of discharge, and some people are worried, not even worried whenever they are wet also. So this is the perception which can vary, and you have to decipher whether it is problematic for the patient or not. So anytime if the patient has to utilize panty liners or pads, or if it is associated with itching, vulval itching, then it is abnormal. The source of this vaginal discharge is vaginal epithelium, cervical, and the upper genital tract secretions. And it could be, along with it, semen also, exogenous if women is using some other components. So let's understand what does this normal discharge composed of. So the routine components can be divided into three parts: host cell components, soluble components, and microorganisms. Right? So these all the components are responsible for the pH of the vaginal secretions. The amount of them is changed according to the menstrual cycle, according to the effect of the hormone, that is estrogen and progesterone, and also the amount of the vascularization in the vaginal mucosa. Why is it so? You have say in that many of the times the patients, women who are having a problem of the constipation or having a PID, whenever the vascularity is increasing, there is a lot of discharge. So these all are the components which are influencing the components of the vaginal discharge. Let's take one by one the each component in slightly detail. So let's take up Yeah. So let's take up the host cell component. So host cell component consists of the epithelial cells, leukocytes, and the immune cells. Epithelial cells um, are coming from the stratified squamous epithelium. We all know there are multiple layers in the vaginal mucosa, starting from the basal, parabasal, intermediate, and the superficial cell layer. And this cell dissection rate is one layer per 4 hours. Remember that the lowest mode cell from the basal layer takes around 96 hours to reach up till the superficial layer. And shedding of this epithelium, which is rich in the glycogen, is a food for lactobacillus, and I will tell you how it is. The other component which is very important is a leukocyte, and mainly the T lymphocytes. Remember that these T lymphocytes are different from what is present in the blood. So the genesis of this T lymphocyte is different from the blood. So it is not coming from the transudation process, right? Then another component is the immune cells, which may vary ranging from NK cells to macrophages. But remember that the NK cell resembled and blood derived ones, and they are coming as a product of the transudation from the vascular epithelium. Uh, Coming to the next component, that is a soluble elements. So soluble elements are coming from the secretion from the cervix and the upper tract. The cervical mucus consists of 2 to 5% mucin glycoproteins, immunoglobulins, and antimicrobial peptides. And these cervical mucus is affected by the estrogen, progesterone, which affects their viscosity, glycogen, and the protein. The glycogen is the main thing which is converted with the help of amylase into sugars, and this amylase is coming from the two areas. Number one is from the vaginal epithelial cells and as well as the bacteria present, and this vaginal amylase 20% is being contributed from the epithelial cells and the 80% is being contributed from the bacteria or the microbiota which is present there. And this is the main component which forms the food for the lactobacillus. Coming to the microorganism component, so there are three components which are dominating: bacteria, viruses, and yeast, out of which bacteria is the most dominant one, especially the lactobacillus we all know. Besides that, there are viruses, bacteriophages, human viruses like HPV, HCV, or palinovirus, and the yeast. So remember that the low level of candida is always present, which is a normal. But whenever there is a problem with the defense system, this candida albicans increases to enormous amount, causing the problem of pathological discharges, right? So host, in general, the host immune factors which are present, I have just talked in the soluble elements, NK cells and everything, and lactobacillus, these are preventing the transition of the candida to the hyphae and the invasion. Okay. Now, I told you that Candida albicans is the main thing. The other variety of the Candida which can be there is a Candida glabrata, which may cause symptom, especially in a diabetes. Now, coming to somewhat detail in the concept of the microbiota, microbiome, and biofilm, because this is the thing which is upcoming, whether it is a recurrent pregnancy loss, whether it is a HPV infection, and cervical intraepithelial neoplasia. So now the microbiota, microbiome is playing role everywhere, right? Not even in the vagina, whether it is a oral, it is a urinary system or a gastrointestinal system. So we must understand the concept of the microbiota, microbiome, and the biofilm. So taking one by one, What does microbiota means? The microbiota refers to the community of the microorganisms like bacteria, fungus, viruses, protozoa, that live in a particular environment in the body. For example, I told you that it can be a vaginal microbiota or a gut microbiota. So vaginal microbiota is dominated by a lactobacillus species, mainly the crispatus and the iners. The gut microbiota is predominantly consisting of bacteroids, E. coli, etc. So it is not the microbiota, these bacteria are same everywhere. These are different at each place, right? So what it describes who is there, the organisms themselves, not their genes and functions. That means how they behave in that environment will be referred by some other terminology. So here it tells you that yes, I am there, but how I will behave, that will depend upon the microbiome. So the microbiome includes the microbiota plus their genetic material, the interaction and functions in a specific environment. So suppose I am Aruna Nigam here as I am behaving like a ISCCP president. But if I am in some other society, I will talk of like CTG or some skill program. So I will there definitely going to behave in a different manner. So that will depend upon the other environmental and the genetic components. So the microbiome includes the microbiota plus their genetic material, interaction and function in a specific environment. And the key component of it is that the microbiome or DNA, RNA, proteins, metabolites, interaction between the microbes and with the host, and influence on immune modulation, metabolism and homeostasis. I hope this makes you understand the concept of the microbiome. So first we have talked of microbiota, then microbiome, and in answers what they do, not just their presence, but the function and the impact on the health or the disease. Now, once we have understood the concept of the microbiome and the biota, let's understand the concept of the biofilm. So, a structured It is a structured microbial committee embedded in a protective slime-like matrix. It adheres to the surface like vaginal epithelium, and it is commonly seen in recurrent infections like bacterial vaginosis, because this bacteria is going to make some protective covering around them, so that body's immune defense system is not going to work against it, right? So if you remember that iron dome, Israel is called as Iron Dome, na? When it has been attacked. So it is type of thing which environment Iron Dome has been created by this microbial community, and now I am not going this routine defense mechanisms are not able to act against them. So it is common in recurrent infection, and it protects the microbes from the antibiotics and the immune response. So let's understand this in this via this table, that the microbiota means the microbes who is present, and the example with reference to vagina is Lactobacillus crispatus and Gardnerella vaginalis. Microbiomes, that means microbes plus their gene, what they do, their function, their interaction, and it is being influenced by pH and the immune modulation. And biofilm is a microbial structure that how these microbes are going to protect themselves. Like Gardnerella biofilm is formed in the bacterial vaginosis. Now coming to, let's understand the lactobacillus, which is very important component of our vaginal microbiome. Right. So this lactobacillus species of the bacteria is the most important component, and a beautiful classification community state type has been given by Reven et al. In 2011. And that is still acceptable, although few more classification has been added to it, but the main classification which I'm going to show is a type 1 to type 5. So they play a crucial role in maintaining the vaginal health through various mechanisms. So you can see here that this epithelial maturation is occurring with the effect of the estrogen, which is causing the vaginal desquamation, which gives the glycogen, and this glycogen is being taken as a substrate after the decomposition by the amylase available by the lactobacillus. And now this lactobacillus produces hydrogen peroxide, bacteriocins and lactic acid, which protects whole of this vaginal epithelium and maintains the pH level between 3.5 to 4.5, and this acts as a defense against the pathogen microbes. So remember that whenever this lactobacillus species is disturbed due to any of the reasons, yeah, like if there occurs a dominance of the any other bacteria, initial phases of the menstrual cycle, or there is lot of discharges from the cervix which is causing this barrier to be affected, then we are going to be prone for the vaginal infections. So as per Raven et al., they have divided this lactobacillus into 5 categories: community stage type 1, 2, 3, 4, 5. Why I'm telling you this? Once those MRs are going to come to you to tell you that my probiotic contains this type of lactobacillus or that type of lactobacillus, you need to see whether it resembles the routine vaginal microbiota or not. So remember these 1, 2, 3, 4, 5, and out of these 1 to 5 are the favorable ones for the vaginal mucosa. So Lactobacillus crispata, Caceres and Jansseni are the most favorable one, which produce the lactate, which is highly stable, helps in the restoration of the vaginal pH, and Jansseni is the largest producer of the hydrogen peroxide, which helps in killing the bacteria. Now coming to the two important types, which if dominates causes the disruption of the routine vaginal microbiome leading to vaginal dysbiosis. So these are the 3 and the 4. The 3 is Lactobacillus iners, which produces insufficient amount of lactic acid and increases the pro-inflammatory factors, which helps in the development of the growth of the other pathogenic bacteria. And community state type 4 actually lacks the lactobacillus and harbors the anaerobic bacteria like Gardnerella, Prevotella and others, and it is generally found in bacterial vaginosis and it is responsible for high vaginal pH. So remember that 1 to 5 are the favorable one, 3 and 4 are not favorable to us. In Indian population, it is the crispata and the casseri which predominates. Now, how the vaginal dysbiosis affects the immunomodulation? So, it increases inflammatory cytokine, impairs the mucosal immunity, and alters the immune cell recruitment of neutrophils, dendritic cells, and macrophages, and influences the systemic immunity also. As we all know, the discharge component differs as per the phase of the menstrual cycle. So during the menstruation, it is important to remember that pH increases, which causes the increase in the iners and decrease in the Lactobacillus crispatus, which causes temporary increase in the lactobacillus bacteria. So similar way, in the infants, it is a estrogenized mucosa, so lactobacillus predominates. Here important thing, the two phases of life which are very important, the postpartum and the menopause, when there is a relative decrease in the estrogen which causes decrease in the glycogen, which causes decrease in the lactobacillus and increase in the pH, and which diverses the microbiome leading to genesis of the vaginal dysbiosis. So similar way, it is the pregnancy. I'm not going into the details of it. So there are several lifestyle and environmental factors which affects the components of the vaginal discharge. Remember that the sexual activity with a multiple partner increases the bacterial vaginosis risk. The routine douching is not recommended because it disrupts the microbiota. Smoking also promotes the bacterial vaginosis, and diet high in fat starch may increase the glycogen, although no proven role of this have been shown. So Indian women, I have already talked of that Crispata gasseri is the main component. Jansseni is mainly in the African females. It predominates, but all the 1 to 5 are the favorable lactobacillus species. Now, hurriedly we will go with the concept of the probiotics, prebiotics, and synbiotics, and what is the literature says about it, not any medical representative or not the studies which have been sponsored by these companies. So let's understand the concept of the probiotics. These are the live microorganisms that provide health benefits when consumed in adequate amount, and it produces lactic acid, bacteriocins, and compete for the binding sites, modulate immunity. So it is a microorganism. Now, this prebiotic is a food for the probiotic, that is a non-digestible substance that promote the growth of the beneficial microbes. And the symbiotic is a combination of the pre and the probiotics for the enhanced effect, enhanced colonization, and improving the vaginal health synergistically. But of course, we need to know whether they are going to help in a different cases of vaginitis or not, what the evidences say, not the experience. It is the evidences which I'm going to talk of. It has been generally said that the use during vaginitis restores the healthy vaginal flora, prevent recurrences of infection, enhances immune modulation, and reduces pathogenic colonization, which is the routine function of any of the pro and the prebiotics combined, right? So let's see. These are the ISSVD recommendations. No other society gives any clear-cut recommendation regarding the use of probiotic, prebiotic, and the symbiotic. ACOGs, only the ACOG is the other society which gives few of the recommendations, where they say as such there is no proven role of any of these components. But the ISSVD says that the probiotics, oral or vaginal, restores the lactobacillus dominance in cases of bacterial vaginosis, and the most studied strain are Crispatus, ramosus, and reuteri, and it can be used as an adjunct to antibiotics to reduce the recurrence, most useful whenever they are used in a case of recurrent bacterial vaginosis. In pregnancy, it has been said that they may reduce the dysbiosis and inflammation, but the role is limited. Still, promising evidence are needed for a safety and a benefit. As such, it is safe. So in vulvovaginal candidiasis, probiotics may suppress candida growth and modulate inflammation. Potential benefit has been observed in recurrent vulvovaginal candidiasis, and whenever you are choosing, you should be seeing the ramosis component, reuteri, and the crispatus component. In aerobic vaginitis, there is a limited evidence. Trichomoniasis, not effective as a immunotherapy. So there are limitation and safety regarding the use of the probiotics, prebiotics, symbiotic. It is generally safe. Strain variability is there. There is a lack of standard dosing. Only few large-scale RCTs are available, and those large-scale RCTs are only in the number of patients of ranging from 84 to 120. This should not replace the primary antimicrobial therapy. Now, this is my last slide. Still, the question remains, what should be the route of probiotic? Many studies are there, but still no clear-cut evidences whether you should be giving it orally or vaginally, although vaginal affects as a local application, and there is more probability of reaching that bacteria directly. What should be the dose of probiotics? Some says I am having a 1 billion, 2 billion, 3 billion, 4 billion, but we don't know, and there is no recommendation regarding the dose of the bacteria in that probiotic. If probiotic is to be added, which component is useful? No evidence is in literature available, and for how long to be given. The range from 3 weeks to 3 months, but we still know the exact dates, how many days this needs to be supplemented as per any of the guidelines and RCTs. I'm not going to talk of what any MR or what any local research studies say, but I have researched a good number of articles and good journal. There are still no clear-cut guidelines on these four components where we still need to do more of the research. So use probiotics as an adjunct in the recurrent bacterial vaginosis, potential benefits in VVC and aerobic vaginitis. There is no strong evidence for use in trichomoniasis, and prebiotics and symbiotics still are the experimental. There is no recommendation from any of the societies on this that we should be using a combination or no combination. So to conclude, I can say understanding of the vaginal microbe is very important. Lactobacillus is the most important component with 1 to 5 as a favorable types. Probiotics are helpful in recurrent bacterial vaginosis, vulvovaginal cadenosis, but role in trichomoniasis is not proven, and we still not clear about the dose and how long we should be providing. Thank you all for your patient hearing.
Thank you, ma'am. It was a wonderful lecture, and having this a complex subject to make it such a simple for us to understand. It was a really crisp message you have given us, especially the microbes as a guardian, understanding the vaginal microbes. And ma'am, one question to you. Nowadays, because of the HPV infection, this microbes, vaginal microbe, is a talk of a town, and the MR, especially, they come and say, okay, this is a treatment for HPV infection. And what is your comment on it? And what do you?
So it is not a treatment for any of the infections. Remember that we have to maintain the vaginal microbiome, because whenever there is a vaginal dysbiosis, it promotes any of the pathogenic bacteria and the viral growth. So vaginal microbiome has to be maintained, and any growth of any other bacteria will occur. But don't think that this is a treatment. If the CIN has occurred, if the HPV infection has occurred, that has to be treated, not by just giving this probiotics and prebiotics. No, there is no role of it in treating those infections. It can be adjunct, but no clear-cut guidelines are there. It has a role, vaginal dysbiosis has a role in the development of the CIN and having a HPV infection or any viral or a bacterial infection.
Thank you, ma'am. Thank you very much. Thank you. Any other one wants to take a question? Ask ma'am any questions, please.
Just a small comment here. This dysbiosis is coming in a big way. And Dr. Aruna, to mention here in our own department, there is an ICMR project which Dr. Bindya is doing, and for the dysbiosis, how it may be involved in the genesis of ovarian cancer using advanced genetic next generation sequencing. So it's a funded project that we are doing in the department.
Yeah, that is a needed, and latest last article just I have screenshot that was regarding the ovarian carcinoma only, where the vaginal dysbiosis has been. So because it causes the growth of the other bacteria and the virus.
Absolutely. So very important subject. Thank you. Excellent talk. Yeah.
We can move further, Dr. Priyanka.
Yes, ma'am. Thank you, ma'am, for the wonderful and informative session. So we'll move on to our second scientific session, which will be a panel discussion on VIN and VAIN, the precancerous puzzle of lower genital tract, for which I would like to invite our moderators, Dr. Bindya Gupta, ma'am. Ma'am is professor at Department of Obs and Gynae at UCMS and GTB Hospital. And Dr. Shruti Bhaskaran ma'am. Ma'am is also professor at UCMS and GTB Hospital. Over to you, ma'am.
So thank you, Dr. Priyanka. And now I would like to invite our panelists. We had a very, very interesting talk by Dr. Aruna regarding the vaginal microbiome. So please show the CV slides, please, Priyanka. So our panelist is Dr. Anshuja Singla. She's a very, very dear friend. She's a professor at our department only in Obs and Gynae, UCMS and GTB Hospital, and is doing a lot of oncology in the hospital. So welcome, Anshuja. Next, Dr. Shruti Bhatia. She's Director Gynec Oncology at BLK Max Hospital, Delhi. Again, very my dear friend. So welcome, Dr. Shruti. Professor Mamta Raga. She's Treasurer of ISCCP, Senior Consultant Gynae Endoscopy and Robotic Surgeon at Sir Gangaram Hospital. Dr. Ashok Padi, again, very dear friend, Dr. Ashok, good evening. All the way from Orissa, he has joined. So he's an associate professor in gynec oncology at AHPG Institute of Cancer in Cuttack and very renowned gynec oncologist. Dr. Rema P. Ma'am, thank you very much for consenting and being a part of this session today. She is additional professor and head of division of gynec oncology at RCC Thiruvananthapuram, Kerala. Ma'am, most welcome. Thank you so much. And nonetheless, Priyanka, you have not put your slide. So Dr. Priyanka Mate is our last panel. She is our associate professor in gynecology in our hospital and a very, very budding laparoscopic and a good surgeon. So welcome everyone, all the panelists. And Dr. Priyanka, you please stop sharing your screen. And now I would like to invite Dr. Shruti Bhaskaran. She is our moderator for the session today. Dr. Shruti, can you share your slides, please?
Sure, ma'am. Good evening, everyone. Sorry, I'm a little under the weather. Dr. Ashok has written that he needs to be unmuted, ma'am. So if someone can do something about that.
Dr. Ashok, you can just unmute yourself. Is it not possible? Dr. Sethi, can you please help Dr. Ashok unmute? Shruti, can you then share the screen, please?
Ma'am, just a second. I'll just share.
Okay, I'll just ask Dr. Sethi to do it.
See my screen? No, not yet. Yes. Can you see my screen, ma'am?
I'll do that, Dr. Bindia. You continue.
Okay. So, Shruti, yes, it's visible. Please make it slideshow.
So, ma'am, we can start with the panel discussion.
Yes, please.
So, it is on VIN and VAIN, the precancerous puzzle of the lower genital tract. So, it will be a case-based discussion. We are discussing 3 cases. So, without wasting much time, we'll start with the case straightforward. The first case is of Mrs. X. She's a 56-year-old postmenopausal lady. She was postmenopausal for the past 10 years. She came to our OPD with the complaints of itching and lesions over the perineum and lower limbs for the past 3 years. She was diagnosed as a case of lichen planus in the derma OPD and was on basically steroidal treatment. She was referred to gynae OPD for further management because she was complaining of vulvar itching. Here on examination, sorry that we don't have more pictures on this, but on examination, there was a hyperpigmented lesion which was involving all the 3 rings of the vulva with satellite lesions over the perineum. On per speculum examination, cervix was atrophic. It was flushed with vagina. PV uterus was atrophic. We took a PAPS which came out to be Etzel. On doing the vulvoscopy, the hyperpigmentation, as already mentioned, was seen involving all the 3 rings with multiple aceto-white areas.
Shruti,
On colposcopy, yes, ma'am.
there is. Can you be a little loud because everybody's writing in the chat that you're not audible.
Can you
Thoda
come
sound.
closer to your computer?
And increase your volume.
Dr. Ashok, you have to unmute on your own.
But he's not able to do it. He's repeatedly writing, he's not able to do it.
No, from there it is not possible because some setting is there in his system.
So, Dr. Ashok can join again.
Okay, Dr. Shruti, you continue.
Can you hear me properly, ma'am, now? Am I loud?
Your sound volume is very less.
Very less, even now?
Yeah.
Acha.
Laptop
Now?
may increase
Now?
to the maximum.
I've done it maximum. Is it okay now?
Yeah, it is much better.
Much better? Okay.
Hmm.
So, on doing a valvoscopy, there was hyperpigmentation, which was involving all the three rings with multiple acetovite areas seen after application of 3 to 5% acetic acid. On doing the colposcopy, because it was HCl, the transformation zone was T2. There were acetovite areas from 8 to 10 o'clock position and 11 to 1 o'clock position. There was no abnormal areas, so sweet score was around 5 to 6. Proctoscopy was also done because cervix and vulva both were involved and it was found to be normal. We took cervical biopsy from all the acetovite areas. The report that came out to be was acute cervicitis with patchy foci of mild to moderate dysplasia. Multiple vulvar biopsies were reported as VIN3, and biopsies from the satellite lesions and perianal region was VIN2. ECC, the tissue was inadequate for opinion. So my first question is to Dr. Anshuja. Is the histopath report of VIN3 and VIN2 consistent with the latest classification of vulvar intraepithelial neoplasia? And what is the latest terminology? Dr.
Okay.
Anshuja.
So thank you, Shruti. So the terminology of Win2 and Win3, it came into being when 1986 ISCCP classification was given when it was HPV associated or HPV independent, followed by repeated revisions, and then we had a last terminology. And finally, 2015 ISCCP said that it could be, if it is HPV associated, it could be LCIL or HCIL. And if it is HPV independent, it would be DVIN or differentiated VIN. And the latest terminology that has come into being is by WHO, which is the 2020 classification, which says that the HPV associated remains the same, LCIL and HCIL, but the HPV independent category has two new entrants to it. The first one is the DVIN that we had in 2015 ISSPD. And the next is the DEVIL, which is the differentiated exophytic vulvar intraepithelial lesion, and the VAD, the vulvar acanthosis with altered differentiation. So we have this, we can say we have five of these now. Two are HPV associated and three are HPV independent lesions.
So very rightly said, ma'am. They wanted to club all the HPV associated lesions in one classification system. That's why they like made it more uniform. So any comment on the devil and VAD, ma'am? How is it different? So what they saw was that the nuclear ATPI is slightly less than DVIN. So
Yeah.
though they cannot, they are still not very sure how much of devil or VAD actually progresses to vulval cancer. But that is what the difference they found between DVIN and devil and VAD. So next question is to Dr. Ashok. So how to differentiate between vulvar HCIL and DVIN, sir? And how does immunochemistry help? What is the role of immunochemistry in such lesions? Sir?
Could Dr. Ashok unmute himself? Okay, I think Shruti, we can ask somebody else. Dr. Shruti, you can take this question. Dr. Shruti Bhatia, ma'am, please, can you just take this question?
Yeah. So,
Yeah, am I
hi,
audible?
good evening.
Am I
Yeah,
audible?
yeah, yeah.
Okay,
Yes,
sir.
yes, you are
Yeah,
audible.
yeah.
Yes,
Just
Dr.
I'm
Ashok.
coming to the question. So, how to differentiate between vulval HCl and deviant? As you know,
Yes.
as you already discussed, vulval HCl is HPV associated and deviant is HPV independent. First of all, things if you want to go by the morphology, by morphologically, vulval HCl is maybe usual type, usual Watty and bacillate morphology. But if you go for the deviant, it is a keratinizing morphology in a background of lichen sclerosis usually. And if you choose the total atypia, you will get total atypia throughout the layers, but only the basal cells and parabasal cells are affected in the deviant. And if you go to I usually it is usually vulval is present in usually young ladies, whereas this deviant in older ladies usually. And usually vulvar HCl are multifocal, and deviant is usually unicentric. And if you go for ISC to differentiate, it's usually HPV, that is P16. P16 is positive in vulval HCl, and P53 is usually negative in vulval HCl. Whereas if you go for deviant, here P16 is negative and P53 is positive. But again, the same vulval aberrant maturation, the devil and VAD, as I already mentioned, sometimes it is also P15 negative, P53 negative. And if you go for Ki67, you will get total epithelium is Ki67 positive in vulval HCl, but only the basal layer is positive in Devian. So that is the difference between vulval HCl and Devian.
Very true, sir. So it is the block positivity that we should focus on. If it is the block positive for P16, it is VHCl and it will not be LCL. And the main thing is to differentiate between DWIN and VHCl. That is our main motto, because our treatment will now depend on what it is. Okay. So to Dr. Mamta, ma'am, what are the various modalities available to treat pre-invasive vulvar lesions, and how do we make a choice like between all the modalities that we have?
Well, thank you, Dr. Shruti. So the various modalities which are available to treat vulval intraepithelial neoplasias could be the medical treatment, ablative or excisional treatment. Of course, what to choose depends on the patient characteristics, the biopsy results, her previous history, any high risk factors, as well as on the basically the location and focality of the lesion. So the candidates for the medical treatment should be, of course, the compliant enough to have a long course treatment follow-up of minimum duration of 6 months, and also those who prefer to avoid the excision and ablative treatments such as clitoral lesions and who wants to avoid the disfigurement. The candidates for the ablative treatment are those who are having multifocal disease, as well as those which have lesions which are involving clitoris, urethra, anus, or vaginal introitus, while excisional treatment is preferred for those who have single lesions in the absence of other features, and the lesion which is doubtful for invasive, irrespective of the biopsy colposcopic findings, as well as in the setting of other high risk factors for invasive disease such as previous vulvar HCl, DWIN, vulvar carcinoma, immunosuppressed states, or the previous history of lichen sclerosus and planus.
Rightly said, ma'am. So we have all these three modalities which can be used for VHCl, but when we are talking about DWIN, it is usually excision that has to be chosen, and none of the ablative or topical treatment will work for them. That is to be made sure. And once we choose ablative or topical treatment for VHCl, we have to be very sure that we are not missing out on any underlying or occult invasion. That can be up to like I think 10% also sometimes in VHCl. And that is how we go about choosing our younger patients. Of course, we would like to go ahead and do a medical therapy or an ablative therapy rather than going ahead and doing a excisional procedure. So this is to Rama ma'am. What is the best option for this particular case that we had just discussed, and for the plan for dealing with the concurrent cervical pathology, that was CIN 2, and should cervical and vulvar pathologies be dealt at the same sitting or separately?
Hi, good evening, and thank you for the invite. Coming back to our patient, she has got a high-grade CIN in the cervix. She has got a HCl in the vulva, and which is multifocal. Rightly, you have taken multiple biopsies, because in the first picture we have seen the previous one. The first picture in your first slide, you have shown the vulva with multiple lesions. So when you have multiple lesions, you should be taking multiple biopsies, because there can be a coexisting malignancy, invasive cancer somewhere. So now we have got a HCl in the vulva, multifocal, with cervix showing a high-grade CIN. I'd like to treat in the same setting. The cervix we can treat by excision LETS procedure. Depending on if she's got a type 2 transformation zones, we can go for a type 2 excision by LETS. And for the vulva, actually we aim and treatment is to prevent an invasive vulva cancer. So I prefer an excision technique, and the excision is not going to be a large radical vulvectomy, because she doesn't need that. She's got a disease which is confined to the epithelium. She's got a pre-invasive cancer. So I'll go for a skinning vulvectomy. That means we'll be removing the skin and retaining the subcutaneous tissue, where you can put a graft, or if you people have closed it. So we'll go for a skinning vulvectomy. And because we don't want to disfigure the vulva, we want to retain the vulvar anatomy as much as possible. And at the same time, we want to treat the pre-invasive cancer also. So here it is away from the clitoris, but we'd like to take a disease with a very minimal margin, like 0.5 centimeters should do a margin of that. So a skin with subcutaneous tissue is removed with a skinning vulvectomy, skin grafting, or a primary closure in easily closing situations, or even a small flap can be used to get a normal functioning vulva. When the lesion is very close to the clitoris or anus, the margin doesn't matter. Just an excision should do. Yeah.
Ma'am, just one question. Like, could she have been a candidate for imicomode or like medical therapy?
Ideally, we don't know. As I said before, we don't know if there is an invasive cancer underlying. So I
Yes,
wouldn't
because
consider imicumod for
she
this
had
patient.
lichen
Yeah.
planus. She was being treated for lichen planus. So we don't know whether at
Yeah.
that time we did not even put IHC markers. So we don't know we were dealing with
Yeah.
DVIN. So yes,
If
ma'am. So excision
DVL,
was
there
what
is
we
no
chose.
medical management for DVL. Even for
Yes,
an HCL vulva, we always prefer to have an excision.
excision.
And even for an extensive lesion, if you can do a skinning vulvectomy, a skin graft or whatever to retain the anatomy, or a primary closure, I'd always prefer an excision
Right, ma'am.
over a medical management. Unless it's very extensive, it's going to the clitoris. Even then, I'll go for an excision, and for whatever is remaining, I can go for a medical management with imicumod.
Right, ma'am. So we also did a skinning vulvectomy for her with a cervical cold knife conization. We did not do a LETS with the vaginal biopsy and excision of the satellite nodules. So again, ma'am, the same was the question was this is a continuation of the previous question. What is the difference between
Yeah.
all these excisional procedures and what to choose, like which method to choose in what condition?
Yeah, I should say that simple vulvectomy is actually something we don't do now. It is something which is previously done. Now we go for the vulvectomy. There is no one single incision. We go depending upon the extent of lesion, where the lesion is, the site of lesion, the extent. So whatever is done usually is a wide local excision. In a pre-invasive cancer, you don't need to go for a 1 centimeter or 2 centimeter margin. We just go for a 0.5 centimeter margin in a wide local excision. For multifocal disease involving whole of vulva, for a pre-invasive lesion, you go for a skinning vulvectomy. For when you're suspecting or when you have an invasive cancer, you go for a radical vulvectomy. As I said before, skinning vulvectomy is just a skin keeping the subcutaneous tissue, while a radical vulvectomy or a radical local excision, you go to the depth of deep fascia. That is how it becomes different. And radical vulvectomy and radical wide local excision is done for an invasive cancer. For a pre-invasive cancer, we go for a wide local excision. For multifocal, like in our patient, we can go for a skinning vulvectomy. Simple vulvectomy, total vulvectomy terms are now usually, I mean, we don't do that now because basically we don't want to disfigure the vulva.
Right,
Dr. Emma, I have one doubt actually. That white local
Yeah.
excision, if you define white local excision, it's about around 1 centimeter margin as all textbook says. So what's your take on it? Is it
Yeah.
1 centimeter or 0.5 cm?
Yeah, it is for malignancy. We attempt at a 1 centimeter margin, and in a fixed specimen, 0.8 centimeter is enough.
0.8. Yeah.
We call it
0.8
margin set.
millimeters.
That's for an invasive vulvar cancer. When you're talking about a pre-invasive cancer, even if your
Definitely.
margin showed a pre-invasive cancer, we don't go for a re-excision. Margin positives are also managed like that. So we go for a 0.5 centimeter excision for a pre-invasive vulvar lesion.
So ma'am, it
When you're
should be a 1
suspecting malignancy, we
centimeter
definitely go for a 1
microscopic.
centimeter, but we do compromise where there is urethra, where there is anal orifice and vagina, and even clitoris. We can compromise the margin.
Rightly said, ma'am. So it should be a 0.5 to 1 centimeter margin. And it is also called as a superficial vulvectomy. And so that is what we had chosen for this patient. And for the focal satellite lesions, we did a wide local excision for her. So this was the histopathology, the final histopathology after the skinning vulvectomy. The skinning vulvectomy showed a VIN3. In the right lateral and left lateral inferior margins, they were all positive for VIN3. The right satellite lesion also showed VIN3. The vaginal biopsy, because it was extending to the upper 1/3 of the vagina, also the white white area. It was only fibrocollagenous tissue and no lining, not positive for any sin. Then the cervical cone biopsy was SYN3 with negative margins. So my question to Dr. Shruti ma'am is how to deal with the positive margins of the vulvectomy specimen, and does it require re-excision at this point?
Thank you, Dr. Shruti, for this question. And as we have been discussing, our main aim is to avoid disfigurement of the vulva. So we have achieved a positive margin in this. We have achieved a good excision, although the margins are positive. But if on clinical palpation there is no visible lesion or no residual lesion on palpation, I think we can leave the patient. We need not go for any repeat surgery, and we can just monitor these patients. And if required, at the positive margins, here we can use the imiquimod cream if required. Otherwise, we can just leave these patients and keep them under close follow-up. We don't want any disfigurement. We have achieved our goal in anyways.
Very rightly said, ma'am. But does it have an impact on recurrent disease later on?
Yes, yes. I mean, that is definitely there. So whenever we are leaving a positive margins, yes, it definitely leads to a rate of excision is much higher in these cases. Although as we have discussed, we should get a negative, but we can leave these patients if it is leading to too much of disfigurement.
Right, ma'am. So that is what the plan should be, not to do it immediately until unless there is a gross disease.
Gross disease, yeah.
Yes. Or any time during the follow-up also, if there is a gross disease, we have
Gross
to do
disease. We are following up these patients regularly for a long time. So we have to counsel them that if they feel there is any lesion, they have to come to us sooner so that we can go for a second surgery.
True, true. Thank you so much, ma'am. So what is the follow-up protocol, Dr. Priyanka, for such patients after excision? And what do we do? How do we follow these patients up? Like, what do we do when we call them up for follow-up?
Actually, these patients of all VIN patients are very highly prone to recurrences, especially the DVIN cases and the high risk patients. High risk patients involve those who have multifocal lesion or large lesion, or whose margins are positive. Or so these patients are kept under closed follow up, and the follow up is usually for lifetime. And initially frequent follow-ups for 3 to 6 monthly follow-ups for initial 2 years, followed by 6 to 1 yearly follow-up for another 5 years, and then annually for their lifetime is recommended. And these patients should always be trained for self-examination if they find any abnormal or new lesion or discoloration or abnormality. So they should immediately report, because between the visits also they can have recurrences. So self-examination is important. Along with that, thorough examination during the follow-up, thorough physical examination of the patient should be undertaken along with local examination, which involves thorough examination of vulva, vagina, cervix, and perianal and anal region. So, if any new lesions are found, then should be colposcopy should be done, and directed biopsy if indicated.
So what about vulvoscopy? Like, is it recommended to be done at every visit, or we
No,
can
not
just
in every visit, but if any new lesion
Okay.
is seen or any suspicion is there, then yes, we should always do do a vulvoscopy and guided biopsy if indicated.
So very rightly said, it has to be a lifelong follow-up, and initially it is every 6 months for 5 years, and then from the last treatment, and then it has to be done annually.
And we also should not forget a CIN3. We have to
Yes.
keep that also into
Yes,
mind,
that
and we have to
also.
do a
So we
test
have to
of
take a
pure
pap
HPV
smear and
testing.
do a
Yes, ma'am.
Yeah, so that we also have to be very careful. Yeah.
patient again was followed up. Like, she came in 2017. This was 2 years before the all the treatment happened. 2 years prior to this, she came in April 2017, where on examination a right inguinal node was palpated and was found to be palpable. So we got a biopsy done, but it came out to be a reactive lymph node and no malignancy. Again, she followed up in 2019. She came to us, but this time she was complaining of vulvar itching and a lesion for 3 to 4 months. So on examination, we found that there was a warty lesion of around 1 centimeter at the clitoral hood, and near the inguino, like the crural fold, there were 4 other lesions of around 1 centimeters. All of them were warty, and one was near the anal opening. So, Dr. Ashok, how will we manage now this situation?
So think that the clitoral lesion, what you say that is 1 to 1 centimeter, may be a recurrence, what I feel. So I want to completely evaluate this patient clinically, again, see and examine with acetic acid of this. I will go for vulvoscopy and see the vagina again to take care of the cervix as pointed by Dr. Bindia. So go for a smear, and again with the anal smear, I will go for that. And if possible, I will take a multiple punch biopsy with case punch biopsy forceps from the satellite lesions, other to 4 lesions we have described as a recurrence, maybe a recurrence. And I will definitely go for excision of that clitoral lesion with adequate margin and depth.
Right.
That is
Rightly
very
said.
important.
Yes, so that is what we did. We did the excision of the clitoral. So what about the anal smear, anal cytology? What is any role of anal cytology when we are following such patients? Actually, what they said is anal cytology doesn't have much sensitivity, though we did see anal examination is much better than that. So here we removed the clitoral lesion, and on histopathology, the clitoral what it came out to be VIN3 with no evidence of invasion. Other satellite lesions all showed fibrosis and sclerosis. Anal smear was normal. So, to Dr. Anshuja, what is the incidence of recurrence and what are the factors that affect the recurrence in such cases?
Mm, there are a few percentages that we need to remember here. The range of recurrence can range from 10 to 50%, and despite any mode of treatment, whatever we have done, the recurrences can range up to 60%. For DVIN, it is around 50%. For vulvar HCL, it is around 10%. So that we need to remember. And these can be associated with 4% of pre-invasive lesions for other genital tract areas also. So the recurrence is there, and that is why the follow-up needs to be recommended to the patient. And a patient whose age is more than 50, she is immunosuppressed. She is HIV positive. She is on immunosuppressant drug. She is a renal transplant patient, and there was initially a very large size of the lesion, and if we could not achieve a negative margin, so these are some risk factors which aid in recurrence. So we need to keep these factors in mind when we prognosticate that patient, and that follow-up has to be reiterated time and again if she falls into the recurrent disease risk factor category.
Rightly said, ma'am. So we followed up in Jan 2020. There were satellite lesions again in perineum and the perineal region. Valvoscopy was repeated for her. There was the clitoral region showed a regression. There was no fresh warts and no estrovite area was seen. So this is what she came back in November 2024, and this is how it was. Valvoscopy was totally negative, and she was win free by that time. So we were dealing with a case which was having recurrent lesions, multiple local excisions were required in this case, and of course disfigurement was a problem in this. So this the last question of this case to Dr. Shruti ma'am. So the follow-up for how long, which has been like time and again we have been saying that, and what is the role of corticosteroids, because she's a case of lichen planus. Many a times lichen sclerosis could also be there. So
Yeah.
any role of concurrent corticosteroids in such cases?
Yes, Dr. Shruti, we have now corticosteroids have proven that they are very effective in decreasing the recurrence, as well as they are also very effective in decreasing the progression to malignancy. They've seen almost like they decrease the rate to half. So there's a 50% reduction in the cases of recurrence as well as progression to cancer. So in these cases, steroids are actually very effective. And as we have already said before, lifetime follow-up is important, as well as we have to counsel these patients for we have to do self-examination, and there is any abnormality, they have to come sooner. Otherwise, regular follow-up lifelong is very important, because we have seen recurrences even after 10-20 years.
Rightly said, ma'am. Thank you so much. So now the case 2, I'll invite Dr. Bindia to discuss
Yeah,
the case.
so thank you, Shruti. And I think very nice inputs from all the panelists for the first case. And now we come to the second case. This lady was a 65 years old, para-3 live-3, a known case of squamous cell cancer cervix in situ cancer. And she had a radical hysterectomy in 2009 in some hospital. And she was referred in 2023 to us for a colposcopy guided biopsy with a PAP wall smear showing HCL with suspicion of squamous cell cancer. She was a hypertensive controlled on amlodipine. Next slide, Shruti. So this was in 2009. She had a modified radical hysterectomy with BSO with pelvic lymphadenectomy, and her histopathology showed squamous cell carcinoma in situ, and there was no LVSI or in the myometrium, and it was normal, and lymph nodes were negative. Next slide, Shruti. So she was referred to a cancer clinic for adjuvant treatment at that time. But in 2009, the histopath review and the cancer clinic showed only focal moderate to severe dysplasia, suggestive of carcinoma in situ, which was a very prevalent term in those times. And radiotherapy was not given, and patient was kept on a close follow-up. Next slide. So, Dr. Mamta, when we have this kind of a patient right now, when suppose carcinoma in situ, or nowadays we just state it is a pre-invasive disease. So, what is the follow-up protocol whenever we have patients like this?
Whether the cervix is there or out, the follow-up protocol is essentially the same, that they need to have a very intensive follow-up, more so because the disease may come back more so in the initial few years, and it has to have a minimum 20 years of follow-up if our age allows. And it is, of course, an intensive follow-up in the first 2 to 3 years. And because it is for carcinoma in situ cervix, so a test of cure is the HPV test, which is the first test done initially at the 6 months, then 12, 18 months. And then one, these three are, if negative, then she goes to have a annual basically testing. You could do co-testing if the facilities are there. We are not wrong in doing co-testing. But yeah, a very intensive follow-up. And once only the first 3 to 4 the test of cures are negative, then the interval may be prolonged, if not 1 year or the 2 years, but it has to have a 20 years follow-up.
Yes, so exactly like the way we follow CIN3. So it's like that. And you're absolutely right. We have to follow up to 20 years. So this patient also underwent a rigorous follow-up. And as you can see, few reports which we had retrieved from her 2009 till 2023 when she was referred to us. So multiple times she had some inflammatory smears. There was some ascus, there was some HSIL, and sometimes she underwent a biopsy. Sometimes she was just followed up. So this follow-up was done in some other hospital. And when she came to us with an HSIL now, then what we did was we planned for we also did an HPV, and it was a 16 HPV 16 positive. Next slide, Dr. Shruti. And so when we examined her, there was everything was normal in the systemic examination, and on per speculum examination, there was no obvious growth on the wall. The vaginal length was 2 centimeters. There was no mass felt, and rectal mucosa was free, parameter was free, and a PET CT also she had got with her, which showed normal, and there was no significant abnormality. And so what we had planned was a colposcopy of the vulva and vagina in view of the HSIL and the 16 positive HPV DNA. Next slide. So this is the findings of the vaginoscopy. So Dr. Rema, I would now request you to just comment on these findings, and also what are the unique difficulties which we find associated with the vaginal colposcopy.
Yeah, before we come to the colposcopy part of it, I have two comments. First and foremost, when you about preventing this, when somebody is planning surgery for a cervical cancer in situ or pre-invasive cervical cancer, we don't do hysterectomy usually, but if hysterectomy is being planned, they should look for a vaginal extent of the lesion, because if there is a vaginal extent, that will come in the vault suture. So whatever we do in the vault, like we are taking a wall smear, but that part which is in the suture will be missed. And this patient, like it happens to us all the time, may come back to you with a vaginal carcinoma, which was all the time inside the sutured place. So it's very difficult to detect it. Another thing, your PET CT is not going to do her any good because you're thinking about an epithelial abnormality. So
Yeah.
PET CT should not be done or practiced in lesions like this. Coming to the question about vaginoscopy, it is technically very difficult. It's not like a colposcopy because it's vagina with all the folds and difficult. You may miss lesions. But here you can see that we have acetovyte areas even in the anterior vaginal wall. Practically the steps are same. You visualize, you clean the vagina, you apply acetic acid. We use 5% because vaginal epithelium, unlike cervix, it's difficult to take acetic acid. But here you can see an acetovyte area in the anterior vagina, in the upper part, I think, and even in the posterior vagina, you can see the acetovyte area, and this must be the acetovyte area which is shaded off. In the picture number 3, I know that my arrow is not working. You can see some white, you can see some white part there, which should be the vaginal epithelium, which is shredded off after, which is peeled off. Like your rack sign in the cervix, this can be a high-grade dysplasia in the vagina. You can even apply iodine. Basically, the interpretation is just like our ISCPC interpretation of colposcopy. We call it a major abnormality and take biopsy from all the abnormal looking areas. Yeah, but
Yes,
it's more
absolutely.
difficult than cervix.
Yeah, absolutely right, Dr. Rema. And what you've rightly said, in fact, whenever we do, even if we want to do a CIN3 or we want to do a radical hysterectomy 1A1, 1A2, we always should, see for vaginal extension, because there is where the recurrence happens, because that comes in the suture line. Absolutely right. And the IFCPC terminology also holds the same for vagina, where we grade them into minor, major lesions and suspicious for invasion. And this was definitely a high grade lesion with all the peeling sign and ester whitening. And as you can see, apart from the folds and all, even the scarring at the top, that prevents from actually the right interpretation of the lesion in these kind of vaults when we are dealing with the sutured vaults. So next slide, Dr. Shruti.
Dr.
So
Maybe can I tell something?
yeah, sure, Dr. Ashok.
Yeah,
Yes,
actually, this is our institutional practice. Usually, we go for a VI and OT also. Even if a VI of vagina, before going for any radical surgery, for stage for
yes.
cancer surgery, stage 1, A1 or A2, if you are going for a modified radical hysterectomy, in OT itself, before starting the surgery, we go for a VI of the vagina and see the extension of vagina, so that how much margin I will take. So even if I examine the patient in OPD, again I do the same thing. This is the
Yes,
protocol in
Dr.
our
Ashok.
institute,
Even we
and
also
that
do
should be
the same.
practiced.
We also do it in the colposcopy 2 to 3 days prior to surgery to see the vaginal extension. And in fact, if it is extending to the vagina, we also adopt the technique of taking a vaginal cuff from below and then proceeding with the combined abdominoperineal approach. So absolutely right. This is very, very important important point which we should all consider before we plan for any kind of radical or a extrafacial hysterectomy, especially when we are dealing with the CS cervix. So now in this patient, it was a vein, a vaginal edsel, and as the picture shows, it was involving the full thickness of the epithelium. Next slide, Dr. Shruti. So this was the diagnosis of the patient. Next slide, please. So, Dr. Priyanka, we just want for theoretical reason, this thing. What are the risk factors for development of vein? We've already discussed we are not doing a vaginal colposcopy before we do radical. They might progress into vein. And what are the regression and progression rates for vein?
So there are various high risk factors, as we saw in this patient also. When there is a history of CIN, or there is history of any associated lower genital tract cancer, and patient had received radiation therapy, and when the patients are exposed to thiolystilbestrol drug, which is nowadays obsolete, but still it's a very important, it has its important role in development of vaginal carcinoma or vein. And immunosuppressive state of the patient, if the patient is a smoker, then all these factors are the risk factors for vein. And the progression rate is around 2 to 7%, and the regression rate is at higher level, it is 85 to 87% overall in 1 to 3, vein 1 to 3.
Okay. So basically, it depends on the type of HPV infection and what we are dealing with. So, Dr. Ashok, over to you. So, how to decide the modality of treatment in this case? Should we go for surgical? Should we go for medical management? And what about AIN? A lot of work these days on AIN these days.
Yeah. So in my view, everything fits not to all the cases, but you have to individualize the treatment. That is very important. So you have to go for the patient characteristics, number one, and most important, the disease extension. How much it is extended in the vagina. That is whether you are able to achieve a clear-cut margin or not. That is most important thing. And what the previous treatment patient has received. These are the factors that will decide your treatment. And particularly in this case, what I feel that it's a medical treatment or any kind of leisure that may not be so effective. So I will definitely go for a radical vaginal vaginectomy. I will go for a total vaginectomy with an adequate margin, because we do not know what is underneath also. There may be some kind of invasion inside underneath. So we should better to go for a surgical treatment in the form of total vaginectomy. That is my option.
Yes, absolutely.
But
and also, there is so much of
if the
fibrosis
patient
in
is
the...
not fit for surgery, then I can consider other option.
Yes, perfect, Dr. Ashok. I think surgical is the mainstay for treatment in this kind of a case. And also, when we have the fibrosis at the vault, the medical absorption of the drugs of imiquimod and all, that is also reduced.
That's
So
doubtful.
therefore, the effectivity also goes down whenever there is a post-surgical, when we are treating with when we are treating vein with medical treatment. So next
Dr.
slide, Dr.
Bindia,
Shruti. Yes, Dr. Shruti. Over to
Yeah,
you.
I have
You
a
have a
question.
question also. You
Acha,
answered
okay.
this
So,
question also.
yeah. So, I have a question here. So, whenever we are planning any medical or surgical treatment in this case, I mean, do you have a protocol? Do you do any imaging like an MRI because or any ultrasound, anything to look for
See, if
any
it
lesion
is,
inside?
yeah, but if it is
Yeah,
vein
yeah, yeah,
3,
yeah. We can
yeah,
go for MRI also.
yeah,
No, it is vein 3, but again, because vagina is a very difficult area, we might be
yeah.
missing
That
out
is what I'm
any
saying. If
lesion
it is vein
inside.
3, if it is vein
So
3,
what
you
is the
can go for
extension, to know the
MRI.
extension of the
MRI.
lesion? The
Yeah,
MRI,
so
MRI is, yeah.
because at our center as a protocol, what we are following up is vein 3 is whenever we see a vein 3, we always do an MRI because sometimes we have seen some thickening which we do miss on.
Exactly.
Yeah, yeah, absolutely, absolutely. You know the digit, exact digit extension of the MRI and plan accordingly also. That is very important.
So you can have another lesion at MRI also. So vein 3 you can do an MRI, but for like vein 1 LCL lesions we can omit. But
Yeah,
for
Yeah,
that's
yeah.
true.
LCL
Yeah, we
we
can
can go
omit.
for, yeah, we should go for MRI. However, in
And
this case, patient was not willing for surgery. She said, in 2009 I've got a hysterectomy done. I've lived well, and she was absolutely not willing. We counseled her so many times in the OPD, but she just absolutely put her foot down. So now coming to this, now the patient is with you. What do we do for medical management in this?
No, as you have said, ki we have to counsel surgery is the first option, especially in a
Yes,
post-surgery, post-hysterectomy case. If the patient doesn't want, then the next best option we have is a 5% imiquimod cream. We apply it 3 times a week for 8 weeks, and we alternate with the clobetasol ointment. So that gives a better absorption and better results. So whenever we are applying, we have to tell the patient. The problem in these cases, if the lesion is high up over the vault area, it becomes very difficult for the patient to apply the drug herself. So it has to be guided, either a medically supervised or such application so that it can be applied to the proper area. It cannot be just a blind application by the patient.
yes, absolutely right, Dr. Shruti. And with a lot of, there was so much of debate going on with the patient in the OPD, but she refused surgery. Absolutely, she said no. She was that I don't want to go for surgery again. So we did amiquimod with her, and we also did the alternating with the steroid application. And we what we did, the first 8 applications we did ourselves only. Then we taught her daughter also. Then finally her daughter used to accompany her in those, for the visits. We taught her daughter, and then the daughter used to apply for her. So Dr. Anshuja, what are the advice when we apply imiquimod? What are the advice we give to the patient? How should we assess on the first follow-up visit?
Okay. So, Dr. Shruti has already said that it's a 5% cream, and that you are the first time that we start Imicmod, it is best to tell the patient to apply it once a week and at bedtime, so that the cream remains in the vagina for at least 6 to 10 hours. That is our main aim. She should not, most of the people do not go to swim at the night, but then she should be avoided. It should be told that she should not go for swimming or take a bath or douching, whatever. If any kind of such practices are there, she should avoid sexual intercourse, because the latex condoms, they weaken, the imiquimod weakens latex condoms. So sexual intercourse should be avoided. And then once she's okay with the once a week application, then it can be successively increased to 3 times a week, because initially it may cause some pain, some burning, some flakiness can be there when you start imiquimod. So slowly she should build it over at least to 3 times a week, and give it for good 8 weeks. Literature says it can go up to 16 weeks. Reassess her, call her back, see, do a vaginoscopy again, put in acetic acid, see if the lesion is there, still there. If it's progressed, take a biopsy. So this is how you follow up these patients. And she should avoid any other medications when she's on imiquimod, because this can, because it's immune modulated drug, so it can have a little sometimes a systemic symptoms also, flu like symptoms with imiquimod. So the patient has to be extensively educated when she is being started on imiquimod.
Yes, absolutely. And so these are burning, local burning sensation, itching, redness. They're the most common, the side effects at the time of vimicomod application. And this is what we have to look for when she comes. So the first follow up, and you're absolutely right about the various the modality, how to use it. So now this patient received vimicomod for 16 weeks, and you can see this was a vaginoscopy done after 16 weeks of application, and the white areas had resolved to a much extent, and even at the level of the vault also, the whiteness had reduced. So next slide, Dr. Shruti. So Dr. Mamta, when we have completed the treatment and we took a biopsy also, it was negative. It did not show any vein. So what is the surveillance protocol after treatment completion? Now what do we do?
Yeah, the surveillance protocol here also is also the same for vein, and it is a long follow-up. It has to be a strict intensive follow-up for initial 2 years, a co-testing preferably 6 monthly interval with cytology and HPV for first 2 years and then annually. Uh,
Yes. So
and if
basically,
you
again,
have a
here also,
finding, then you do you need to take the call accordingly.
and even when she comes to you, I mean, good, visual inspection is required. And if suppose there is any suspicious area, we can apply acetic acid in the OPD and see under magnification also. So in this patient, the follow up was done 6 monthly. Wall smear was also done. Lately, in July 2025, she had an HCL on the Pap smear, and we repeated the colposcopy. But now this time it was vein LCL. So again, the patient refused excision. There was no. She said, "Napki bar, I will also." We thought it is not responding to Imicumod. She said something was this is. So we decided to go for 5-FU cream this time, and we gave her weekly 2 grams. And now patient will come next month. In the meantime, she lost her son also and took some accident. And then very surprisingly, her daughter delivered with us, and she had warts at the during the pregnancy. So she was treated for genital warts during pregnancy. The daughter used to stay with her only. She used to apply that cream for her. So I don't know how it is related, but then she also had warts and she underwent treatment during pregnancy for that. So right now the patient has not come to us. So we will probably in the next session tell you what happened with the 5-FU. So she's on close monitoring again. So this is we do the second case is ended. So I think we are already 8:20 is there, Dr. Aruna. Shall we now continue or shall we just stop it?
Hello.
Yeah, it is
It's
8:20.
8:21. How many minutes you will take?
Shruti,
Not
can you
more than
just
5 to 7
just show the
minutes I'll give you.
images in 5 minutes and we can just ask quick questions from all the
Okay, five
panelists. Just
minutes
show the
and then we
case.
will wind up.
Shruti, are you there?
Yeah, ma'am, I'm here. Can you hear me?
Yeah,
Hello?
your voice is very soft, low.
Now, can you hear me, ma'am?
Closer, closer.
Now, can you hear me
Yeah,
now, ma'am?
okay.
So this was a 43-year-old. She came with itching in the perineum for the past 10 years. She had undergone a Okay. She had undergone a vulvoscopy 2 years back in our GTB only, where a small white lesion was seen in the labia majora and the biopsy had shown VIN1. So she was kept under follow up. But she came back to us saying that she has severe vulval itching. So we again examined her. This time, as you can see here, there was a white hypopigmented lesion on the right perineum involving the labia majora also. You can see this. This was after the application of acetic acid. So perianal region and the perineal body wala region and the labia majora. So this was involved. HPV DNA that was done was negative. So on histopathology, on taking the biopsies, it came out to be moderate dysplasia with HPV-like changes from the vulval biopsy. So this is to Rama ma'am. What further management for this case, since it is a multifocal in a large area, medical or surgical, and why?
Yeah, we can actually combine both. We can go for an excision, but as you can see, this lesion is going very close to the anal orifice. So you may get a margin positive there. You may be leaving some residual disease there. So primarily, I think I'll go for an excision. And for whatever is left near the anal orifice, I can put an imicumate for that. You can even do it in the other way. Apply a imicumate, wait for 4 weeks or 8 weeks, and then go for an excision after that. But I'd prefer to go for a primary excision because I want to rule out an invasive carcinoma anywhere. And then
Right.
if it is, yeah, for the anal orifice part, I can apply Microbes.
Yeah, though this is the latest Lancet, the publication, a randomized control trial, where they actually found that imicmode was found to be non-inferior to surgical excision with reference to complete remission of the disease. So
Yes, but you
here we
need
did actually did a, yes, ma'am.
multiple biopsies to make
Yeah,
sure that there is no
yeah.
invasive area.
Yeah,
Mm.
we took the multiple biopsy. It came out to be VIN2. So we did an excision for this patient, and we advised imicmode application for the perianal region, the white lesion in the perianal area. The final histopath was VIN2 and the margins were negative. So, for Dr. Shruti ma'am, what is the risk for VIN in the background of lichen planus?
Actually, this
In the
patient also, she was followed in
Yeah.
dermatology where she
Sorry.
was found to have they also did another biopsy. She went there and there was a lot of itching. So they were diagnosed as lichen planus and they did a biopsy there.
I think this patient has both HPV as well as the lichen condition. So in these cases, the chances of VIN is pretty high. So, and sometimes seen, I mean, a patient with such a large lesion, they are coexisting. So many times we see DVIN and a lichen infection coexisting. So there's a very high chances of progression to VIN in a background of lichen. Actually, we see more of lichen sclerosus. Planus is much less, but it is very high.
True, ma'am. Lichen planus are slightly lesser chances
Yeah.
of VIN as compared to sclerosis. So this is the follow-up in 2025. She again came with the problem of itching is persisting. In between, when she went to the private hospital, there an ablation was also done, which the records are not available with us. So in 2025, when we did the vulvoscopy, we can see this. This is the area of excision which we had done. Here, these are nevi that we can see. And here is after application of acetic acid, acetoid area can be seen in the middle ring. So we had biopsied this lesion and it came out to be WIN1. So the dermatologist had advised her for lichen planus, tacrolimus, and she's also applying mometasone, both. So, ma'am, what is your take on the tacrolimus and its effect on WIN? Will it help or does it have no effect? Or is it like any opinion on that?
Hello.
Yeah, Dr.
Hello,
Ashok.
sir.
Yeah, am I audible?
Yes,
So
yes.
in this case particularly, I will prefer to go for excising that lesion.
Okay.
Even if it is VIN1 under the background of lichen planus, so I don't know. So better to go for a excision of that lesion.
Okay.
Dr. Anshuja?
Yeah, I think it's a persistent disease. It is better to excise it. Why to leave it? It is being there. It is not responding to
Yeah.
practice.
That's
And
why it is a
recurrence.
persistent.
And
Some
recurrence
kind of
is there.
persistence
Mometasone
we're
The
Yeah.
getting.
follow-up.
mometasone is a very ultra potent steroid, more than clobetasone actually. So if she's
Yes.
not responding to that, then better to have a little deeper
And
excision.
and also, there are some melanocytic spots also
Yeah.
closer to that lesion.
Yeah.
So I think they also are pretty doubtful. So yeah, this patient has just come to us. So we were now in the process of counseling, and we are planning to do some excision of this area. But again, she's a staff at a hospital, and she is on her own trip, and she just wants to just decide on her own the second excision. So I think with this. We thank all the panelists, and anybody wants to give one or two comments, please, most welcome, and then we can wind up.
Yeah, there are
So
also, yeah, sorry.
in all vulvar diseases, what I feel that we do not know, there may be something underneath. So we should be very cautious about dealing such cases, and proper evaluation, and maybe a little bit over treatment may be appreciable in all the cases. That is my take on total.
There is something like a therapeutic HPV vaccine after treatment for VIN
Yeah.
into excision
That's
and
that's
then
there.
give
That was
vaccine.
one
We
of
should
the
not forget
questions
that.
we wanted to ask, ma'am.
Yeah,
What about the
not
HPV
covered.
vaccination in both these cases? Would you
Yeah.
advise?
Yeah. I'd just like to
Yeah.
add that whenever we are treating these patients for VIN or dermatosis, we have to tell them that they would require a lifetime follow-up. And we have to tell them that it is something which they have to follow up closely. It's not something like it will get treated. It can recur and they have to be very careful with the follow-up. And a self-examination is again very important with the mirror and by looking at the area so that they know and they can pick up the lesion soon.
Yeah.
Absolutely.
Yes, Dr. Anshuja.
Yeah, I actually also wanted to, just highlight this as follow-up is very important, very, very important. It's just not that we've done a surgery or we've given her medical treatment that she's happily sitting home. If she's not coming to us, we need to somehow contact the patient and get her back. That is very important.
Dr. Priyanka.
Very rightly said, ma'am. Yes, the follow-up is very important. And patient should also be educated for self-examination, which is a must. And she should report immediately, and lifelong follow-up is a must.
So with this, I think thank you very much, all the panelists. It was an excellent discussion with such good take-home messages. And thank you very much for being there in this panel discussion. And thank you so much, Dr. Shruti. Over to you. You can conclude the panel. Shruti is the person behind this webinar today. She's the convener. So over to you, Dr. Shruti, for your vote of thanks, and please conclude
Thank you
the
so much,
webinar
Dr.
today.
India, for all the guidance, and I'm like honored to have such esteemed panelists with us. Like we were able to discuss this important issue, and I thank Dr. Aruna Nigam ma'am for giving me this opportunity, and Priyanka, who was a master of ceremony and conducted it so well, Dr. Sandhya, Dr. Archana, and Dr. Anjana ma'am. Thank you so much for giving it.
Shruti, will you give me 1 minute? I will. I
Yes,
have one
Dr. Aruna,
request
please.
I have one request from all the academicians in this group, that kindly submit at least one article to the Journal of Colposcopy and Lower Genital Tract Pathology, as I had to take out the issue by the end of December. So I need your contribution to take out the issue, so that we will have a good indexing as well. We are indexed, but I'm trying for a PubMed indexing and a Scopus. So for that matter, I need the help of all. So it is an utmost request.
Yeah, same from here also. Yes. So thank you, Dr. Aruna, and for giving the opportunity this time to our hospital. And Dr. Shruti did a very good job for being the convener of this webinar. So thank you, Dr. Shruti, for agreeing to it and for making a wonderful scientific program. And ISCCP is really proud of the monthly webinars, which have been really appreciated. Our attendance goes up to more than 100. So excellent participation. So now for next month again, 7 December, at 7 p.m. for 70 minutes. We have another very, very interesting webinar. Dr. Helen is the convener for the next time, and she's going to discuss the various modalities of treatment for CIN. So till then, have a good month and have a great time. So good night, everyone. Thank you very much.
Good night.
Thank you and good night.
Thank you. Bye-bye. Thank you, ma'am. Thank you so much for joining. Thank you.